So I want to welcome everybody to the March Virtual Lyme Impact Session. Really excited for this evening's presentation. We have a Lyme literate medical doctor, Daniel Kinderlehrer, that really combines an integrative approach with the mind-body healing aspect, as well as traditional pharmaceuticals. So I think that integration is very, very meaningful. Before we introduce Dr. Kinderlehrer, I just want to give a couple of really quick updates. My name is Eric Huck. I'm a co-founder treasurer of PA Lyme. Our moderator this evening is William Moore. He's on the board of Pennsylvania Lyme, and he's our IT technical expert when it comes to all things related to that level of importance for organizations, certainly during COVID. We are holding the Virtual Lyme Impact Sessions every third Tuesday of the month. April is going to be a really good one, I think, and it's going to be a patient panel. I run the Harrisburg Lyme region. When we do monthly meetings, we usually always have a good speaker. On the months where we have a patient panel, the turnout is even that much more. I think genuinely that is what people that have chronic Lyme want to participate in. They want to know what others are doing, how are they getting better, why are they getting better, what's working, what's not working. And the April Virtual Lyme Impact Session will have three individuals with chronic Lyme who are winning. They are not cured, but they're learning to work within the confines of their condition to be able to be productive and functional. As we were putting this together, we're also going to have a Lyme doctor on that panel. We know that a lot of the questions that we're going to get in the April session are going to be very specific and really best answered from a medical professional. So be on the lookout for that one coming up in April. The May Virtual Lyme Impact Session will be a preventative presentation, a Lyme prevention education. It's going to be structured on our DARE program, which is what we use we've done hundreds and hundreds of educational trainings for high-risk groups. There are some new things to be aware of as 2021 unfolds spring into summer, and we'll be covering that in May. I want to really just go to a share screen and have everybody look at what I'm putting up here. What I'm showing you here is, this is Dr. Kinderlehrer's new book. Timing is everything in life. And 90% is just showing up and just kind of putting yourself out there. When we reached out to Dr. Kinderlehrer and we really solidified on March 16th, he said, "Well, what a coincidence. That is the day of my release." So his new book that you can see right in front of you, this is the dust cover. And I think the introduction by Dr. Burrascano is meaningful, and you'll see that there's others that we hold in esteem in the Lyme community have also voiced in about the importance of this particular book. Pamela Weintraub, one, as you can tell, Dr. Golan, as you can tell. So we're lucky really to have Dr. Kinderlehrer with us today. And just by way of introduction, I would like to give a little bit of a bio and an overview. He is nationally recognized. He is a physician, medical doctor. He does specialize in areas of nutrition, allergy, environmental medicine, and Lyme disease. What I appreciate about his discipline and his protocol is the ability to kind of intertwine the healing of the mind, body, and spirit as a unified whole. And so part of his accolades are he co-founded the New England Center for Holistic Medicine in Newbury, Massachusetts. And that distinction is important when you buttress that up against the other fact that he organized the Lyme Fundamentals, which is taught annually at the ILADS conferences nationally for ILADS. So his integrated medical practice in Denver, he focuses on diagnosis and treatment of tick-borne diseases. So as an author of the new book, Recovery from Lyme, an integrated medicine guide, this is really a step, a continued step in that direction to be educating those of us that need to really get better and have a better understanding of the condition in which we have. We're very, very pleased to have you, Dr. Kinderlehrer. With that, let me cover one last thing in housekeeping. So the way this is set up, if you're new, is if you're on Zoom, you can go to the bottom and you can see a Q&A button. You can go down there and ask your question. If you're on Facebook and you are live streaming right now, real time, you can go into Facebook and you can make comments and ask questions. Bill Moore will gather the questions. He'll prioritize, organize, and at the end of the session, we will have no less than 15 minutes and maybe as much as 30 minutes of Q&A. And that's where the power really is of these types of presentations. It is certainly beneficial to hear an expert give an overview of all of the complexities of what we need to know to get better. But it's another thing to understand, how does that impact you? When you ask your question, what I would ask you to do is ask it in a generalized fashion. Try not to personalize it too specific to your situation. Try to elevate it to a more generalized type of a question so that it's more applicable to the larger audience as whole. So you can ask your questions with that button at the bottom throughout the whole presentation, and then Bill will take over. So with that, Dr. Kinderlehrer, thank you again very much. Allow me to turn it over to you.
Well, thank you so much, Eric. Excuse me. Like you said, this is an auspicious day for me. It took me about 4 years to write this book, and today is the day it's being published and released, and it's just a great day. I'm very grateful for the invitation to present here. As you know, excuse me, as you know, I'm a former resident of Pennsylvania. I grew up in Allentown, Pennsylvania. I have siblings who still live in Pittsburgh. And so, I just have affection for Pennsylvania. I went to college at Franklin and Marshall in Lancaster, Pennsylvania. And so I feel a little nostalgic talking to this Pennsylvania Lyme support group. It's great. Eric invited me to give this lecture in a timely way. And I asked Eric, well, what do people want to hear about? And he said, I'm sorry, he said, well, there are some people who just aren't getting better and they want to know, like, what else? What else can they do? And I understand that Tom Moorcroft lectured recently on co-infections and so on. So I'm sure you folks know everything you want to know about co-infections. I'm actually decided to prepare a talk that I entitled, What If It's Not the Bugs? I mean, what else is going on besides these bugs? So I'm going to now share this PowerPoint screen and pray that it all comes up the way it's supposed to. And there we go. I'm getting a nod from William Moore. We're good to go. So the title of this talk is Lyme Disease Complex. It's not just the bugs. Okay, let's talk about what chronic illness is. I want to make a distinction between acute illness and chronic illness. Acute, in medical parlance, acute means recent. So let's say recently you got, 2 weeks ago, you got a bellyache and diarrhea and nausea and vomiting and a fever. Okay, probably there is one cause for that illness. But if you have a chronic illness, something that's been going on long-term, I can guarantee you it is multifactorial. And that's what Lyme disease complex is, multifactorial. It's important to note that virtually all chronic Lyme patients have co-infections. This is really important. We're not just talking about Lyme. And that's the reason I use the the nomenclature of Lyme disease complex, because it's not only Lyme disease, it's Lyme disease plus co-infections, and it's the downstream issues that include all sorts of problems with the endocrine system, that is the hormones, the immune disruption, autonomic nervous system problems, detoxification issues, and so on. All of these are incorporated in that term Lyme disease complex. We also have to realize that there are upstream issues. By upstream issues, I'm referring to issues that preceded getting Lyme disease. What if, for example, you have genetic mutations that involve detoxification, or if you have a prior mold exposure or other allergies and so on? All of these are issues that can become worse because now you have multiple infections. I want to make a general point here, which is that if a patient comes to me who's been chronically ill, really almost all my patients have been sick for years, some have been sick for decades, and some of them, quite frankly, are quite fragile. And in those patients, I am not going to start treating these infections right off. I'm going to work on infrastructure, and that's what we're going to be talking about tonight. Okay, so here's Lyme disease complex. It's Lyme disease, it's the co-infections, and then it's hormone disruption, it's immune dysfunction and sensitivity issues and mast cell issues, nervous system dysregulation, gastrointestinal problems, activation of dormant viruses, and detoxification problems. And here are the co-infections. I'm not even going to bother to read them. I'm sure you've all seen them. That's not what we're going to be talking about tonight, although I'm happy to answer questions about any of them. I'm going to start off with hormone disruption because I think of hormones as really foundational to everything that happens in the body. And I'm going to start off by talking about the adrenal glands. The adrenal glands have sort of two parts. They put out a whole symphony of hormones. One part of the adrenal glands puts out adrenaline and noradrenaline, otherwise known as epinephrine and norepinephrine. And this is what comes out in the so-called fight or flight response. Let's say you have a sudden accident, say you were in a car accident, suddenly, you're in a state of shock and there's a lot of adrenaline going. At the same time, there is increased output of cortisol and DHEA. Well, when things settle down, that adrenaline goes away. But let's say you're chronically ill. Your body continues to augment its production of cortisol and DHEA to help your body deal with the increased demands of infection. Well, over time, the adrenal glands can lose their reserve, and instead of putting out more cortisol and more DHEA, it's putting out less. And that's tired adrenals or adrenal insufficiency. Very, very common. I'd say half of my patients with chronic Lyme have some degree of adrenal insufficiency. And this results in fatigue for sure, decreased immune function, which is important. But I think of cortisol and DHEA. I think of these hormones, which we know, by the way, is stress hormones. I think of these hormones as WD-40 for the cells in the body, that enzymes get rusty without adequate amounts of these hormones, everything slows down. So virtually all my patients, when I first see them, I check their cortisol levels, I check their DHEA levels, and there are various ways we will treat them depending on the situation. And I've mentioned a bunch of them there. I'm not going to get into specifics of treatment. It's really individualized for each patient. Okay, what about the thyroid? Well, this is important because most docs, if they're checking for a low thyroid, which is associated with fatigue, they'll do a TSH, thyroid stimulating hormone level. And if the TSH is elevated, understand TSH goes inversely to hormone production. So if you have low thyroid production, TSH will go up. And if they don't see an elevated TSH, they'd say, you're fine, your thyroid's fine. It's not adequate testing in this situation. We need to get not only the TSH, but the T4 thyroid hormone level, the T3 thyroid hormone level, and a reverse T3, which I'm going to talk about in a minute. If you check out LabCorp or Quest, they'll usually say a TSH up to 4.5 is normal. Not in my book. I would consider anything greater than 2 is suspicious. bottom line though, we treat the patient, not just the lab test. And so we're always putting together the lab data and the patient. Okay. When we're replacing thyroid, it's important that we don't only replace it with T4 levothyroxine, which is generally what endocrinologists do. T3 is very important. I'm going to come back to why it's so important, but that can be done either by giving natural thyroid supplements like Armour Thyroid, NP Thyroid, or compounded thyroid, or the levothyroxine plus liothyronine. These are the normal prescription T4 and T3. Now I'm going to talk about this reverse T3 problem, and I'm going to go to the next slide. And there we are. Here is our hypothalamic pituitary thyroid axis. So what's the hypothalamus? That's considered maybe a central switchboard for hormones, and it sits in the center of the brain, but on the bottom. And it sends out releasing hormones. And these releasing hormones go down the pituitary stalk, which sits right under the brain, behind the eyes. And the pituitary, in turn, sends out 9 different hormones. I think the pituitary is an amazing gland. It's about 1 centimeter big. It's like the size of a pea, maybe, and has 9 different hormones, each under its separate feedback and control mechanism. I think that's pretty amazing. Okay, one of the hormones that it sends out is TSH, thyroid stimulating hormone, that circulates in the blood, and it tells the thyroid to produce and release T4 and T3 thyroid hormones. It turns out that T3 is much less bound to protein, and therefore it's more available to do the work. What is the work? The work is T3 binds with receptors on the cell membranes, and it gives a message. The message is increase the rate of metabolism, that is, make more energy. Okay, well, the thyroid gland makes mainly T4, not T3. It turns out that T4 away from the thyroid gland is converted to T3, and then T3 does the work. But here's the problem. T4 can also be converted to reverse T3. What's reverse T3? Well, it's an isomer of T3. It looks almost like it, but what it does is it actually is a competitive inhibitor. It binds with the same receptors as T3 and blocks the action. I refer to it as evil T3, or T3's evil twin brother. Okay. Well, normally T4, maybe 20% is converted to reverse T3. But in situations where there's a lot of inflammation, and there are other conditions as well, there's certain drugs and low selenium and things like that, up to 50% of T4 can be converted to reverse T3. And what happens? It's blocking the action of T3. So that even if you have normal hypothalamic, pituitary, and thyroid glandular function, you're actually getting some inhibition of that function at the cellular level, and you're functionally low thyroid. So one of the things that I measure is reverse T3 and look at the ratio of T3 to reverse T3. And if that ratio is low, then I'll actually give extra selenium, and I'll give extra T3, which is liothyronine by prescription. That can make a big difference. People usually will say, you know, I really notice a bump in my energy by virtue of taking that. What else can go on? Well, I was just describing my favorite little gland, the pituitary. The most common problem we see with pituitary dysfunction is low antidiuretic hormone. What happens? Well, antidiuretic hormone is a messenger to the kidneys that says, concentrate the urine. So in other words, hold on to some of that fluid so that your pee is going to be a darker yellow and more smelly. That's what antidiuretic hormone does. What happens if we don't have antidiuretic hormone? Well, it's the equivalent of taking a diuretic. And then you have lots of urine. People with low antidiuretic hormone or no antidiuretic hormone, they pee a lot and they drink a lot because they're thirsty all the time. And when I ask them, I say to people, well, do you pee a lot? And they'll, most commonly, I hear this over and over, yeah, but I drink a lot. And the answer is, actually, it's the other way around. they drink a lot because they pee a lot, and they're always dehydrated and trying to catch up. And this level of dehydration not only contributes to fatigue, it contributes to dysautonomic issues, which we're going to be talking about. You simply don't feel that good when you have this condition and you're continually dehydrated. Not only that, but you're getting up to pee 3 or 4 times a night. You know, you can't hold on to your urine, and you're you're drinking a lot of water every day. If people are interested during the Q&A, I'll talk about treatment to that. By the way, that condition is known as diabetes insipidus, not to be confused with blood sugar issues. That's diabetes mellitus, totally different condition. What they have in common is people pee a lot, and apparently that's what diabetes means in Latin, Greek, Roman, I don't know, but that's what diabetes insipidus and diabetes mellitus have in common. Other pituitary problems include low sex hormones, estrogen, progesterone in females, testosterone in males, low growth hormone, and then of course low gonadal function. This is low ovarian function, and low testicular function can result in low sex hormones too. These are things that I routinely measure in people when it seems appropriate, and then replace in an appropriate way. And it can really make a difference in terms of balancing how people feel. Insulin resistance. This is a big one. This is really a big one because sadly, we are a population that has been gaining weight. And what happens? Well, okay, I'm going to describe normal blood sugar insulin curves. When we eat sugar or carbs, then our blood sugar goes up. In response to that, our pancreas secretes insulin. What insulin does is it attaches to cell membranes, to specific receptors on the cell membranes, and it gives a signal. The signal is open the doors, let that sugar into the cell. It can metabolize it for energy and other reasons. And then the blood sugar level goes down. Okay, well, when that goes down, then the insulin should go down too. But what happens if the insulin comes knocking on the door of the cells and the cells don't respond? That's insulin resistance. And here's a diagram where, I wonder if I can use, I can. Okay, so here's someone who's fasting, they have a sugar or carb meal, their blood sugar goes up, and normally the insulin will go up, and as the blood sugar comes down, the insulin will come down. But if the insulin goes knocking in that door and the cells don't respond, then what happens is the insulin levels go up. Now I lost, there we go. Go up and up and up. And what happens? Well, high insulin levels result in inflammation. They result in abnormal weight gain. This high insulin is sort of a messenger that says to the cells, okay, we want you to turn this sugar into fat, not for energy. High insulin levels result in fatigue. This is, some people say, you know, whenever I have a high carb meal, I get tired and sleepy. This is probably why. Unless, of course, you're sensitive to those carbs, like you have a gluten sensitivity or wheat sensitivity, or candida for that matter. Okay, what else? High insulin increases the risk of cardiovascular disease. It decreases resistance to infection. You can see why this could be a big problem if someone has Lyme disease complex. High insulin eventually leads to diabetes. You know, initially as insulin goes up, it can keep the blood sugar levels down, but at some point it just doesn't work anymore, or the pancreas gives up and doesn't even put out insulin anymore. And these people are at high risk for adult onset diabetes mellitus. How do we treat it? Well, first and foremost, and this can make a big difference, is a low glycemic diet. What's a low glycemic diet? Technically, what it means is a diet that's low in foods that stimulated insulin response. What that is it's sugar, it's most grains, certainly all the gluten grains. It's corn and it's rice. And I'm not talking about about brown rice versus white rice or whole wheat versus white bread. I'm talking about all of those and are, have high glycemic indices. And in other words, we're talking about something that is more towards a paleo type regimen can be very important. And by the way, this is used for weight loss all the time. There's so many high protein, low carb weight loss regimens, and it works. There are other supplements that I've put down here, chromium, alpha lipoic acid, Gymneva, that can help stabilize blood sugar. Metformin happens to be the most common drug that's used to try to stabilize blood sugar and help the cells respond better to insulin. Okay, now we're going to talk about the nervous system. As I'm sure you folks know, even though Lyme disease perhaps is best known for causing arthritis, really the nervous system problems are much worse than the musculoskeletal issues. When people are suffering, sure, muscle aches and joint pains can be severe, but I can say that the people who are suffering the most, in addition or instead, have really severe nervous system problems. So first, we're going to talk about dysautonomia. Dysautonomia refers to abnormalities in the autonomic nervous system. What's the autonomic nervous system? You can think of it as the automatic nervous system. So these are things that you don't have to think about. You don't have to think about how hard your heart should be. You don't have to think about how fast your heart should be. You don't have to think about where the blood should go, depending on whether you're running and climbing or sitting and snoozing or digesting. The autonomic nervous system is dealing with all of that complexity. There's two arms to the autonomic nervous system. The sympathetic arm is an accelerator. It's activating. In fact, the sympathetic arm is what stimulates the adrenals into the flight or fight response. Parasympathetic arm, for the most part, is relaxing. So what I'm talking about is you have an accelerator and a brake. And the whole intention of this accelerator and brake is to keep you in homeostasis so that you feel even. What happens with dysautonomia? You don't feel even anymore. So it commonly results, the most obvious results of dysautonomia are fluctuations in blood pressure and pulse. POTS stands for postural orthostatic tachycardia syndrome, a fancy way of saying when you stand up, your pulse races. Really not uncommon. Despite the fact that your pulse is racing, frequently people will feel lightheaded as well as feeling palpitations. Neurally mediated hypotension is when people stand up and their blood pressure drops. People can easily have both POTS and NMH. And there are different ways we can intervene with those. And again, if people want to ask during the Q&A, I can talk about that. But there are other symptoms associated with dysautonomia: shortness of breath, anxiety, flushing and mottling. And I want to point out that dysautonomia can generate mast cell degranulation. And then you have, histaminic type responses. Gastrointestinal symptoms: bloating, constipation, nausea, vomiting, reflux. Neurogenic bladder, and this is like all or nothing, meaning incontinence, which is all, or failure to empty. You can't empty your bladder. These things can happen as well. Excessive sweating or lack of sweating. Heat and cold intolerance can each or both occur. Erectile dysfunction in men. I'm just going to mention here that people with severe dysautonomia, they almost always have babesia. Babesia causes the worst dysautonomia for reasons I don't know, but when I see severe dysautonomia, I'm always thinking, I bet this person has babesia. And I should mention that people are very worried about their heart when they feel their heart beating really hard, pounding heart, and fast racing heart. The problem is not the heart. The heart's just where it's manifesting. The problem is the nervous system regulation. And for the most part, the heart is fine. But it can be really uncomfortable. I can tell you when I was sick with this, and I've been very sick with Lyme disease, I really know this from the inside out. I could lie down on a bed and my heart would pound so much that you could actually see my body move with each beat. And I'm not the only one. I've had patients describe the same thing, and one of my daughters had it as well. Okay, what else with the nervous system? Well, central nervous system is the brain, the midbrain, the spinal cord, but think about brain on fire. I want to point out, when we're talking about these infections, we're not talking about infections the way we usually think of them. So if you're thinking about a strep throat or a wound infection, that's when there is a local invasion and destruction of cells, and then there's a local immune response with inflammation, and what happens then is it kills the microbes and then starts repairing the cells, and hopefully everything returns to normal, okay? Basically, in those cases, the infection is attacking hardware, our cells. These infections don't attack hardware much. What they do is they attack our software. They attack our regulatory systems. And I already mentioned, the endocrine system. I've talked about the autonomic nervous system. Well, it also attacks the brain. So when I say attacks, I don't mean that we have bugs in our brain, which we may or may not have, but what we have is a lot of neuroinflammation, brain on fire. We have antibodies to our nervous tissue in our brains, and actually in our peripheral nerves too, which I'll get to. It disrupts brain function, it disrupts neurotransmitter function, it disrupts blood flow to the brain. And this can result in pretty awful symptoms. I think among the worst symptoms associated with Lyme disease are the mood abnormalities, depression. People here probably know that suicide is the most common cause of death in people with Lyme disease. It's awful. Anxiety, which includes panic attacks, irritability, which can manifest even in rage episodes. I'm sure the audience is probably nodding their head when they hear about this. PANS, pediatric acute neuropsychiatric syndrome. I wish I could see the audience to see how many people are just acquainted with the terminology here, but I'm going to start with PANDAS. PANDAS stands for Pediatric Autoimmune Neuropsychiatric Syndrome Associated with Streptococcal Infection. So Susan Sweeto in 1994 described kids who would get strep infections and then would fall off a cliff with psychological and behavioral issues, particularly OCD, anxiety, depression. They would become irritable and oppositional and sometimes rageful and a whole bunch of other abnormalities. That's PANDAS. Well, it turns out that it's not just strep that does it. Some tick-borne infections do it, like Mycoplasma and Bartonella. We don't know yet if Borrelia burgdorferi, the pathogen of Lyme disease, does it. But and then there are a host of viruses that we know can trigger the same thing. And what's been demonstrated is that these kids have antibodies in their brain, and they have enzymes that are activated that disrupt dopamine, and they're quite sick. Okay, so among the things that they can manifest with, besides the terrible anxiety, OCD, and eating disorders and so on, is psychosis. And we see bipolar disorder and impaired cognition, brain fog. This is a very common symptom, as I'm sure you all know. Peripherally, so the peripheral nervous system is once the nerves come out of the spinal cord and then they go everywhere. So what happens is these nerves get inflamed, and the sensory nerves when they get inflamed, it manifests as pain that is often described as burning, stinging, sharp, or shooting, as well as sensory abnormalities like pins and needles, numbness, and creepy crawly sensations. And if there's motor function involvement, then people will describe weakness and paresis or even paralysis, pointing out that the most common bugs that cause these symptoms are Bartonella and then Babesia. And frankly, most of my patients have both Bartonella and Babesia. Okay, moving right along. We're up to gastrointestinal issues. Well, I would say at least half of my patients have issues with their GI tract. Well, no surprise. I mean, remember the gastrointestinal tract has more immune cells than the spinal cord. I'm sorry, more nervous cells, more nerve tissue than the spinal cord. That has more immune cells than the rest of the body combined. It sends out its own hormones. I mean, it's really quite fundamental, and no surprise that things go awry. So here's some of the things that we see. Any one of these could be a lecture in itself. So maldigestion, low stomach acid. I don't know if that's coming as a surprise or not to you folks. All we hear about from gastroenterologists is high stomach acid, and they want to put, it seems like everybody, on protein pump inhibitors, which I think is a terrible idea. Turns out that a significant percentage of my patients have low stomach acid, and low stomach acid typically presents with bloating, gas, constipation, often belching, and the sense of fullness as soon as you eat, because it takes a long time for the stomach to empty. Pancreatic insufficiency, basically the pancreas is not putting out enough digestive enzymes. That tends to result in looser bowels, also gas, undigested food or pills that you see in the bowel movements. Bile acid deficiency, basically the liver is not making enough bile, or the gallbladder is not concentrating it appropriately, or it's not getting released. And in that case, we tend to see fatty food intolerance, and often acolic stools, which is a fancy way of saying they're no longer brown. They tend to be lighter colored. What else? Food intolerances. We see so many sensitivity syndromes, and these food intolerances can manifest with every gastrointestinal symptom you can imagine. These are the most common foods that my patients are sensitive to: eggs, dairy, yeast, and gluten. But trust me, the sky's the limit. I mean, I see patients who are sensitive to a whole lot of different foods. These are simply the most common. And then, of course, there's dysbiosis. It's basically alterations in the microbiome. People often will ask me, hey, is it okay to take these antibiotics? I'm going to disrupt the microbiome. And the answer, yeah, we probably will. We can do a lot to try to maintain a healthy microbiome. I always recommend high doses of the different probiotics. And if people are going to be antibiotics, I'm always giving them also anti-yeast agents so the yeast doesn't overgrow. But sometimes even before these patients are antibiotics, they have candida overgrowth symptoms, small intestinal bacterial overgrowth, which you folks probably know about, but again, is a whole lecture in itself. The most common symptoms would be bloating and gas, and depending on what's overgrowing, you might have diarrhea or constipation, often belly cramps, nausea, parasites and worms. Wow. Those of you who know Dietrich Klinghardt, he's always said everybody's got parasites, and now I'm beginning to agree with him. A quick story. I had a patient who has diagnosed with Lyme and Babesia, a 60-year-old female. And we were treating her, and she was about 80% better. She did have some gastrointestinal symptoms that were much better when we took her off of gluten. Then she comes in for an appointment, and she tells me this story. She says, I was online, I was seeing this group, and they were talking about Mimosa pudica seed, and I decided to take some, and I couldn't believe what came out of me. She described tapeworms and other worms coming out of her. And this is a nurse, by the way. This is an ICU nurse who knew what she was talking about. Couldn't believe it. Well, I started giving this Mimosa pudica seed to patients who had ongoing inflammation, and we thought we were treating everything. And over half the patients would come in and say, oh my God, I can't believe what came out of me. And this is resulting not just in better gastrointestinal function. This is people, their inflammation, their joint pains, their brain fog, their energy all improves when we treat these, because they're triggering systemic inflammation. So I've come to believe that most of us are harboring these critters, but they're not a problem. They're just part of the trillions of microbes that we live with until our immune systems go awry, and now they're generating inflammation. Okay, Gastroparesis is a fancy way of saying our gut doesn't want to move. It's like paralysis of the gut. And Virginia Scher, who is a psychiatrist from Pennsylvania, I've known her for 20 years, she coined the term Bell's palsy of the gut. And we do see neuropathy of the intestines. And this is most common in my experience with Bartonella. And then there's leaky gut syndrome, which can occur at the same time as all these other conditions. When there's inflammation in the gut, it disrupts the normal absorption mechanisms and boundary function. So here's what I mean. We have this paradox of function with the intestines. The paradox is they're supposed to absorb nutrients, but keep out toxins and not allow food particles in that are not adequately digested. When someone has leaky gut syndrome, otherwise known as increased intestinal permeability, what happens is that people are malnourished, that the nutrients are not properly absorbed, but macromolecules that shouldn't get through do get through. And these add burden to the liver, they become a detox issue, but they also stimulate more immune and hyperinflammatory responses. Okay, moving right along, immune dysfunction. Sensitivity issues. You know, once we get infected with these bugs, I talked about how they whack the immune system, and now we don't have normal immune system function and we become much more sensitive. I'm just going to talk a little bit about immune system function. Here's what a healthy immune system should do. Healthy immune system can look at a molecule and say, this is self and this is non-self. So it can say, in my case, this is Dan Kinderlehrer, and this is something other than Dan Kinderlehrer. The next thing a healthy immune system does is it says, or it delineates, is this non-self a threat or is it benign? And if the third thing it does is it says, if it's benign, I'm not going to do anything. I'm going to let this dust particle or this mold spore or this wheat or gluten, I'm just going to ignore it. We're fine. But if it's a threat like this virus or bacteria, I'm going to efficiently eliminate it. That's a healthy, well-balanced immune system. Well, the immune system gets whacked with these infections and it's no longer healthy. And now it's reacting to a lot of things that it shouldn't. So I have a lot of patients with multiple food sensitivities, most of whom did not have these, or if they did, they were not nearly as significant before they got these tick-borne infections. And again, you know, I mentioned this before, the most common food sensitivities I see are dairy, eggs, yeast, and gluten. And of course, I see lots of other food sensitivities in addition. These are simply the most common. We're also seeing many more problems with inhalant and particularly mold sensitivity. It's interesting that I have patients with Lyme who are living in a house with a mold problem, and other people living in the house, they're not affected by the mold, or at least not obviously, they're not sick. The patient with Lyme, very sensitive to the mold. I see this over and over again. We become more sensitive to it, and then we start that problem of mold toxins, which I'm going to come back to. But I'm just going to say, I live in a dry state compared to you folks in Pennsylvania. I can't believe how many houses have mold problems. I mean, it can be actually hard to find an apartment without a mold problem. I have patients looking, and so all it takes is some moisture to get trapped behind a wall or under an eave or under a sink. Boom, you got a mold problem. And these indoor molds associated with indoor water damage, they put out toxins. I'm going to come back to that. Okay, as we develop sensitivity issues, many people develop MCS, or multiple chemical sensitivity disorder. Now people are reacting to low doses of chemicals that are ambient in the environment, and that basically, if you're not a hermit, you can't avoid. So we're talking about perfumes and hairsprays, as well as you go into any public bathroom and they have these air fresheners, which are terrible, fabric softeners, awful. And people have scented candles, just awful scents. And those sprays that like Febreze, please don't ever get them. So people become sensitive to very low concentrations of these things. And now we're seeing more and more people with sensitivities to electromagnetic fields. Most people are not aware of it, but some are. Some will say, you know, I can't go into a house with Wi-Fi on, my head gets rattled. Or if I take a cell phone and put it up to my ear, my brain starts to vibrate and I can't think. This is going to become an increasing problem, just like foods have become an increasing problem, and mold and chemical sensitivity is an increasing problem. Another generation, EMF, particularly because of 5G and just technology that's unavoidable, it's going to be an increasing problem. Autoimmunity. Okay. So, you know, I talked about this a little bit when I talked about the inflammation in the brain. What these bugs do is they stimulate our immune systems to attack our cells. That's autoimmunity. You know, I'm just going to give a simple example that most of us know, and that's rheumatic fever. Okay, what's rheumatic fever? You get a strep throat, antibodies to the strep attack the heart valves. Because there's some sort of structural similarity between the strep microbe and the cellular structure of your heart valve. That's rheumatic fever. So is it an infection? Yeah, you know, you have a strep infection. Is it autoimmunity? Absolutely. It's our bodies attacking our cells. Well, in this case, our bodies attack our cells. And, you know, it can happen in the joints, and it can happen in the brain, and it can happen in the nerves. We see a lot of people develop syndromes that look like multiple sclerosis and rheumatoid arthritis and lupus and other connective tissue disorders. But when we treat the Lyme disease complex, amazing, they go away. Mast cell activation syndrome. Okay, mast cells are primitive white cells, very early white cells that are designed for protection. And within the mast cell, there are almost 200 preformed mediators that impact inflammation. And when they're stimulated, they release these mediators in an act referred to as degranulation. They release these mediators, and now there's an inflammatory response. The one that's most well known, of course, is histamine. Histamine is released from these mast cells, and then you get an allergic response. In fact, you can get anaphylaxis. That comes from mast cell activation, but it can cause systemic inflammation in general. It can cause symptoms all over the body. If someone has full-blown mast cell activation syndrome, which I rarely see, by the way, when it's full-blown, but if they have it full-blown, they're flushing all the time, and they have hives, and they have shortness of breath, and they can have diarrhea and migraines, whole kit and caboodle. More often, they have part of that. And the obvious question is, well, what's triggering the mast cell activation? What's making these mast cells degranulate? And the answer is lots of things, because they become sensitized. Their threshold for degranulating goes down. The Lyme bacteria can trigger mast cell degranulation. So can insect bites and cold and all sorts of foods and other allergies. And then people with severe mast cell activation syndrome have to eat specialized diets that omit foods that tend to activate mast cells, or foods that actually have histamine in them. Again, a whole other lecture. And what about immune suppression? Okay, so here we have this immune dysfunction, and it does two things that are whacked. One is it overreacts in the form of sensitivity issues, and the other is it underreacts in terms of dealing with possible infections. And where we see that the most is decreased capacity to clear infection, which is why is it so hard to treat these bugs, but also viral activation, which I'm about to get to. Okay, a couple different scenarios. Sometimes people get a tick bite and they get an infection, but they're not sick. It's just dormant. They have an immune system that's keeping it quiet. Then they get a virus infection, such as mononucleosis, and suddenly the tick-borne infections flare. Okay, even more common than that, though, is when people have ongoing tick-borne infection. So they're dealing with Lyme disease complex. And then it activates otherwise dormant viral infections. So most of us have been exposed to viruses like Epstein-Barr virus and cytomegalovirus and others, herpes viruses and so on. And these might be dormant, but once we get these tick-borne infections, they flare. And then that adds to our inflammatory symptoms and makes treatment more difficult, but particularly fatigue. I would say that's the biggest symptom we associate with viral activation. And we look for antibodies to Epstein-Barr virus, which is the virus that causes mononucleosis. Most of us have been exposed to us. Most of us have antibodies to that. Cytomegalovirus, human herpes virus 6, herpes simplex virus 1 and 2, which is what causes oral and genital herpes. These are really common viruses that many of us have been exposed to, but you need to be careful when you're testing for these. You need to be careful in terms of interpretation of the test, because many of us have IgG positivity, which simply reflects a prior exposure, not an active infection. But if IgM and IgG are both elevated, probably that's an active infection. Or if the IgG levels are not just mildly elevated, but really high levels, even with normal IgM levels, that's probably activation of a dormant infection. And then there are a host of ways that we can treat it. There are pharmaceuticals like Valtrex and sister drugs of Valtrex, like acyclovir and Famvir, Valsite. There are botanicals. Byron White makes AEBH6 and Beyond Balance makes IMNV. I mean, there's really quite a few things. Other nutraceuticals, transfer factor plasmide, which is made by Research Nutritionals, which is really programmed to act against these viruses. Vitamin C, both oral and IV in the form of Myers infusions. Monolaurin, another nutraceutical that people often take to help with viral infections. Toxins, okay. We're going to talk about mycotoxins. So I already mentioned molds. Molds are a big problem. 10 years ago, I thought of molds as a problem. Maybe I should look at molds as a problem in people who aren't getting better. Now, I look for mold as a problem on day one, just because it's so ubiquitous. People are having so many problems with mold. And that's, like I said, right here in Colorado. So again, the molds associated with indoor water damage, this is mainly Aspergillus, Penicillium, Stachybotrys, which is black mold. These all three of these and other indoor water damage molds elaborate toxins. Toxins are poisons. They impair immune function, endocrine function, and neurological function. I mean, these toxins have even been tested as biowarfare agents, okay? These are not good for you. So what happens when we're exposed to these molds, we actually can inhale and ingest mold spores, and now we have colonization of these molds internally. Now, even if you're no longer exposed to the mold externally, let's say you've done super mitigation on your house, there's no mold there, or let's say you've moved and you have an absolutely clean premises that you live in, but you could still have endogenous internal growth of mold or fungi. Mold and fungi are the same thing. And what happens? Well, these endogenous molds continue to elaborate toxins long after the mold exposure. Quick story. When I turned 65, I did a mold toxin test because Medicare pays for it. Well, I figured, what the heck? And I was astonished. I had a really high level of mold toxins, probably because I grew up in a 60-year-old house in Allentown, Pennsylvania. I don't know. I was never aware of living in a moldy premises. But what I did was I started taking binders to remove the mold. I was doing saunas, and also I was taking an intranasal antifungal spray to kill mold in my sinuses. After 4 months, I repeated the mold toxin test, which is a urine test, and there was no change at all. So then I started taking itraconazole. itraconazole is a systemic antifungal, so it's killing mold inside me. And 4 months later, I recheck, it's down 50%. I continue the itraconazole, it's down another 50%. So this to me was like clear cut. We're talking about endogenous mold in so many people who have these mold toxins. I'll also mention that if you're having problems of peeing a lot and thirsty a lot, I was talking about diabetes insipidus or lack of antidiuretic hormone. Most of the time, it's associated with mold toxins. Not 100%, but 90% of my patients, it's mold toxins that are doing that. Okay, and how do we treat it? Well, the binders, the systemic antifungals like itraconazole, which I mentioned, and also sinus antifungals and other things we do to encourage detoxification like glutathione. Okay, heavy metals. It turns out that an enormous number of people have high levels of different heavy metals, but lead and mercury are the most common. Basically, it's in the air, it's in the water, it's in fish. It's in fish so high that the FDA recommends that any woman who is even thinking about getting pregnant in the future should avoid like 6 different fish species. You can find this on their website. Also, silver amalgam fillings. These are, just what it sounds like, dental fillings, a lot of mercury. Okay, what do these toxins do? The same thing as mold toxins do. They cause immune, endocrine, and neurologic dysfunction. And they are going to contribute in particular to fatigue and brain fog. Important not to rely on blood tests. And by the way, I don't think hair analysis is such a good way to test for this either. Excuse me, because these don't hang out in the blood. It's like Lyme. Lyme doesn't really hang out much in the blood either. That's why it's hard to find it in the blood. We look for antibodies when we're testing, right? Well, they hang out in the tissues, and particularly they hit nervous tissue. So what we do is we give a chelating agent, which is a binder. And this binder attaches to the metals and then takes them out, both our urine and our stool. Usually we'll measure the urine because it's a lot easier than collecting and measuring stool. And then we treat it with these same chelating agents, and we give supportive detox therapy when we do it. If mercury is high, we're going to have people make sure they don't have any silver amalgam fillings, which is a major source of mercury contamination. Okay, methylation. Okay, methylation is complicated, and there's no way I can do it justice here. Suffice it to say that methylation occurs in almost every cell of the body. I'm just going to skip. Excuse me. Here's a methylation map. I think it's elegant. It's wonderful. And of course, I can only even explain or understand even parts of it, to be honest. But suffice it to say that it is the major cellular detoxification cycle. That is, that methylation occurs in virtually every cell of the body. And it's supposed to recirculate metabolites that occur in the normal process of metabolism. Okay. In addition, though, it processes neurotransmitters and sex hormones. It produces energy. It regulates glutathione, repairs DNA, turns genes on and off. I mean, methylation is really, really important. And unfortunately, many of us have mutations in methylation. And frankly, I don't think it was a very big problem up until recently, when our detox systems got overwhelmed by the multiple insults of the 20th and 21st century, which include not only these bugs, but of course, the hundreds of thousands of xenobiotic agents in the forms of pesticides and herbicides and all the other poisons that we're subjected to. First thing I usually do is a DNA analysis for MTHFR mutation. And if people are really sick, I'll do a broader analysis as well. I'll just point out, since I have I have a pointer here. THF is folate. Folate is a B vitamin and occurs naturally in foliage, hence its name. And THF is, I lost my pointer again, somewhere, there we go. So THF gets converted through that MTHFR enzyme to 5-methyl tetrahydrofolate. That's the active form of folate. Okay, many people have significant mutations in their MTHFR gene, which codes for MTHFR. And you can see that if this is slowed down, and it can be slowed down 70% if you got this gene from both parents, then this whole cycle slows down. Well, if this cycle slows down, this cycle slows down, and this cycle slows down. You can see how even one gene or 2 gene mutations in one enzyme is going to cause a problem. At any rate, we're in really sick people. We're looking at a lot of these mutations, but we're also looking at the intermediaries. Homocysteine be the most common one, but we can measure methionine, we can measure SAMe and cystathione, and right down to glutathione and so on. People are really sick. Really, it's worth looking at these because, again, this is foundational to cellular metabolism. Okay, I'm wrapping it up, folks. So when we're treating Lyme disease complex, this is a big deal. There's so many things that can be out of balance. And I'm speaking as a physician now. What's really important is we see the whole patient. We see, understand everything that's going on. It's so important that first of all, we validate their experience. Sadly, most of my patients have been to dozens of doctors. I suspect the same is true for those of you who are listening to this. And often they're really maltreated. I still, to this day, have patients who go into an emergency room with some problem or an urgent care center, and they might mention, well, I'm being treated for chronic Lyme and I'm taking this and that. And the doctors yell at them. I don't really understand. There's no such thing as chronic Lyme. I could tell you so many awful stories about that. And I think it's so important for those of us who are treating you folks to get it, to understand that, whoa, this is a real problem. And and also understand that previous experience with physicians in itself can cause PTSD. So it really necessitates that we have to really care, be compassionate, understand, be patient. Safety, sadly, people with Lyme disease complex typically haven't, because of those past experiences with doctors, but maybe also because of core experiences from childhood or from whatever, have not experienced safety. And remember, if we don't experience safety, that results in immune dysregulation. So it's really incumbent on us physicians to provide a safe container for healing. And it's important for us to be gentle. And what I mean by that is I know physicians who say, oh, well, you got Lyme, Babesia, and Bartonella. We're going to put you on these 3 antibiotics full dose, start them tomorrow. Oh my God, patients hurts. And at the end of a month, they feel like they want to die and they never go back. I never do that. We start one thing at a time, usually at half dose. Make sure that you can tolerate it before we go on to the next. And I make a point of letting my patients know that if they're having a problem, they can contact me by email and I will do my best to respond within 24 hours. Finally, particularly the first time I see a patient, I think one of the things that I can offer is hope. I would say 90% of my patients get somewhere from 80 to 100% better. The other 10% usually do get somewhat better. There's still a lot we don't know. But when I turn to a patient at the end of an intake, which typically takes 3 hours the first time I see a patient, I'm happy to tell them, I think you're going to get better. And here's what you can expect. And say, there'll be windows when you'll be like cleaning the glass and it feels somewhat more normal. And slowly you're going to have more windows and they're going to be even cleaner and bigger and so on. And there's going to be some Herxheimer reactions. We're going to do the best we can. to mitigate those because they're really not good for you. And so it's really important, good communication, good consistency, and compassion. One of the things Eric didn't mention is that I suffered from Lyme disease really badly. It's how I got into this field. In the old days, 20 years ago, ILADS physicians, most of us, either we ourselves had Lyme disease or a family member had it. It was quite personal. And we found out that, well, guess what? Mainstream docs have no idea what to do. Now, thankfully, 700 to 1,000 people come to the ILADS conferences, professional conferences, and that's great. But suffice it to say that those of us who've been there really know this complex well and committed to do our best to help you folks out there. So that's it. Thank you so much for giving me this opportunity. And I'm going to try to close this thing if I can. And then, hold on. Do I know how to do this? I don't know how to close it, but I'm happy to answer questions. Bill, did you want to pass on some questions for me?
Yeah, thank you, Dr. Kinderlehrer. That was excellent, and really, you really hit on a lot of things that have plagued me with my Lyme disease story. A lot of the mold illness and mast cell activation. So I really appreciated it. And yeah, we have a long list of questions backed up, so I will get started. The first question is, a couple of people were asking, what is the name of the product that you mentioned that was for getting rid of parasites and tapeworms?
Okay, so particularly worms, more so than the protozoa which is what we refer to when we typically say parasites, even though that term is used generically. Mimosa pudica seed. Now it's very interesting because Mimosa pudica is an Asian herb that's an anti-malarial, and we use it for babesia. Now that herb comes from the leaves and the stems, and it's actually one of the good herbs that we use to treat babesia. The seed is very different. It doesn't hit babesia at all, but instead it hits worms, and people tend to tolerate it quite well and are amazed at what comes out of them.
Okay, great. Do you recommend any good anti-yeast products?
Well, yes, I do, for sure. Most of my patients, if they're on pharmaceutical antibiotics, I'll prescribe nystatin, NYSTATIN. Nystatin is, ironically, comes from a mold that was found in New York State, hence NYS statin. And so that is by prescription. It only works in the gut. It's not systemically absorbed unless you're taking ridiculously high doses. If I want to give something more systemic, I'll recommend fluconazole or diflucan. And I'm going to point out that while it hits yeast, and it's a very good anti-yeast medication, it does not hit the broader spectrum of fungi that generate mold toxins. Okay, but there are things that you can take over the counter that are pretty good for yeast. I mentioned probiotics, but Floristar, and which is Saccharomyces boulardii, is sometimes referred to as yeast against yeast. And then there's caprylic acid, which is a coconut derivative. There is Thorne makes something called SF722, which is undasolinic acid. These are good antifungal agents as well. By the way, some regular herbs like oregano and olive leaf, they also have anti-yeast properties, and they hit some of the tick-borne microbes as well.
Okay, next question. For those of us who have treated for years with an LLMD and have gotten well and are able to exercise vigorously, how important is it that we continue treatment?
Whoa, I can't give you a definitive on that. I think it's a great question. When I have patients who go into remission, I basically give them a choice. I say, we don't know, and we have no way of discerning, are these bugs still there? I assume that they are there just because we definitely see people relapse. But I say, I'm going to suggest that you stay on these herbs for at least a year or so, and let's see what happens. And then if you want to stop. But if you start, but be vigilant. If any symptoms start to come back, let me know right away. It's wonderful that I have patients who've been off everything for years and they're still good. And so we can say, well, they look cured, but LLMDs generally will avoid that word cure because we have no way of knowing has the bug been eradicated or not. But ideally, we've knocked it down and supported the immune system to the point where our immune systems can keep it in check and are no longer reacting in an inflammatory way. But I can't say that we have a definitive way of knowing, who's going to relapse and who's not going to relapse when we stop all treatment.
Okay, Dr. Kinderlehrer, I had somebody submit a question ahead of time, and it's a 10-part question on disulfiram. So before I ask all 10 parts, let me ask you, do you treat with disulfiram, and do you have an opinion on treating with disulfiram?
Yes, I treat it, and yes, I have an opinion.
Okay, let me make sure I at least cover the highlights of this question then. So this person wants to know, is disulfiram your favorite treatment? Do you believe it's a game changer? And what is the dose that you would recommend? And what would be some of the reasons that disulfiram treatment doesn't work for some people?
Okay, the first thing I'm going to do is recommend that people go to LymeDisease.org. I've written at least 3 different articles on disulfiram, and you can certainly find them on the website of the California Lyme Disease Association. And I think that will offer more details than I can give in this setting. Disulfiram is a breakthrough drug for Lyme disease. That said, it also has potential for toxicity. It is not tolerated by many patients and needs to be prescribed with caution. So I do prescribe it, and I'm very careful. I start with very low doses, typically around 1/8 of a 250 milligram tablet, which is 31.25 milligrams, every 3 days. And then we slowly build up. But I have many patients who can't get up to a full dose, which is 4 to 5 milligrams per kilogram. And I have some patients who don't tolerate the lowest doses. I have they herx on the lowest doses imaginable. And I have some patients who develop neurotoxicity, sometimes not just at high doses, but on low doses. And neurotoxicity can cause peripheral neuropathy with numbness and tingling, as well as neuropathic pains, but also brain toxicity with mood symptoms and head pressure and headaches and fatigue syndromes and cognitive impairment. These happen, can happen with disulfiram. When we started using disulfiram, we thought we were pretty safe because it's been used for 70 years. We prescribed for 70 years to alcoholics. And they tolerated it really quite well at pretty high doses. And we thought, well, if they did well on it, shouldn't our patients do well on it? Well, it turns out Lyme disease complex patients don't tolerate disulfiram nearly as well as alcoholics do. Go figure. And we're seeing a lot more side effects. So I can tell you that I do use it. I use it with caution. I start very slow. I actually have patients checking in with me every 2 weeks when they're on this. We don't increase the dose more often than that. I give them a lot of liver support. I also have them take supplements to help with their nerves. as well as other anti-inflammatories. They have to be on specialized diets. And interestingly, I see some patients who on very low doses are dramatically better. And I've described this in the last article I wrote for LymeDisease.org, which is in November of 2020. So I suggest people read that. Now, instead of pushing to get to people to the so-called target dose, which was the original strategy that Dr. Ken Liegner, my colleague, has been using, when I have patients who are doing well on a lower dose, I just stay on that lower dose and keep them on it for quite a while. And then after they've been on it 6 to 12 months, we stop it, see how they do. So far, many people are doing well. And then other people, particularly if there's an outside stressor, can relapse and we have to put them back on the medication.
Okay, very good. I've had several people want to know your opinion on Lyme patients getting the COVID vaccine.
Wow, really good question. You know, Lyme docs are very careful around vaccinations because there's a subset of people who react to any vaccine. This is usually related to the adjuvants. Almost all vaccines have these extra ingredients that are actually designed to upregulate the immune system. In other words, cause more inflammation so that our bodies will react more to whatever the attenuated virus or whatever's in that vaccine and produce more antibodies. But guess what? Those adjuvants, when given to someone who's already in a hyperinflammatory state, can crash them. And all of us Lyme docs have had patients get a routine vaccine like a flu vaccine or something and crash. They can totally relapse or end up with migraines for a month and so on. So I can tell you that 2 months ago, I was telling people, my Lyme patients, to wait. Let's see what happens with the vaccine. And so far, so good. That is, I am seeing reactions, but they're usually less than, they're usually just 3 or 4 days. And so far, very minimal reactions that last more than a week. And we're seeing the same reactions people without Lyme. So I'm crossing my fingers that people are doing okay on the vaccines. And I am recommending that people get the vaccines unless they have a history of significant reactions to prior vaccines. And then I'm suggesting they don't get them.
Okay, very good. Somebody wants to know if you're accepting new patients, and I'm going to add to that question and ask if you treat patients remotely.
Okay, well, right now I'm only treating people remotely.
Okay.
Like for the past year, because of COVID-19 has really changed my practice. I am accepting new patients on a limited basis because I simply just don't have room to accept a lot of patients. But if patients call the office, what we can do is put them on a waiting list and then call them when we have spots open. And I do end up seeing a couple new patients every month at least, which I'm glad I'm still able to do. One other thing I'm going to mention, though, is sometimes people call and they have not yet been properly tested for Lyme disease. And just as a service, I offer to get them tested at IGeneX. I can arrange for that to happen from a distance. So for a minimal fee, if patients need to get tested, what they do is they call, my secretary tells them how we do it. We send them a requisition. IGeneX sends them a kit. They get their blood drawn. I get the results 3 weeks later, and then I call them up and spend 5 or 10 minutes on the phone. I go over the results and tell them, what do I think? So I can offer that as a service for those people who have not been tested. While we're talking about that, testing for Lyme disease is really suspect in most commercial labs. I do recommend only specialty labs, and IGeneX is the one that I have that I'm most conversant with.
Okay, very good. Someone is asking if you have any suggestions to help with multiple chemical sensitivity.
Wow. Yeah, boy, this is so hard, so hard. I mean, I know so many people with MCS, including my wife and my secretary. My secretary was so great. She ran IT for United Airlines, and she had to quit because of her MCS. She couldn't go to the office anymore. Obviously you have to have a safe environment, and most people with MCS know this. They know to get rid of all sorts of things in their house that could be problematic and get HEPA air filters and so on. There are supplements that can help, like vitamin C and selenium and glutathione. Even those people need to be careful with. Remember that people with MCS usually have food sensitivities as well. Vitamin C, most vitamin C is based in corn, and that can be a problem. I mean, you really have to get well educated. I can tell you that it's important to treat all of the other sensitivities, and that will help. So that means, making sure that your diet is really clean in terms of what you can tolerate. It means making sure you're not exposed to mold. And it also means, lowering your exposure to EMFs. I don't have a cordless phone in the house. Cordless phones, even when you're not using them, they're generating enormous amounts of EMF. Cell phones, not good. Obviously, Wi-Fi, that's a problem. So there are things you can do to mitigate your exposure to those as well. Certain binders, now I haven't had experience with this, but a colleague of mine has said that she's getting good results with a binder. Actually, it has humic acid and fulvic acid. It's made by the same Cellcore people who provide Mimosa pudica seed. But Research Nutritionals has also come out with a binder with fulvic acid and humic acid. It's very interesting. I don't have this clinical experience yet. This is a clinician that I have a lot of confidence. She says it is really helping. Saunas have to be started slowly, because if you start mobilizing toxins faster than your body can get rid of them, it's going to feel like a hertz. It's going to be a massive inflammatory reaction. But saunas with a lot of detox support, that infrared saunas in particular. And if you're going to buy an infrared sauna, you need to buy one that doesn't have any glues. Now I'm trying to think the name of the sauna company, which, wow, it's in my book. There's two sauna companies that were making saunas without glues, or else get a used one where it's all outgassed. But that's really important too. The saunas are great. And I think in my clinical experience, that has helped people with MCS more than anything, on top of everything else I said.
Okay, very good. Somebody wants to know, do you feel that that Lyme can cause severe psychiatric symptoms?
Yeah, well, yeah, I talked about that. There's no question. In fact, I've just released a couple papers in the peer-reviewed literature on this. This is interesting. A colleague of mine and I tested 10 kids at random. They were at an adolescent residential treatment center with serious psychiatric problems, so severe they couldn't hack it at home, they couldn't go to school. They were all diagnosed with major depressive disorder. 7 of them had generalized anxiety disorder. They had other issues, including cutting, including suicide attempts. I mean, these poor kids were really troubled. And they did not have any known organic illness. And we took 10 kids at random. This was just published, people can look it up. We took 10 kids at random. And I'm going to give you numbers that are a little bigger than what it says in the literature, because in the literature, I had to stick to the very conventional diagnostic criteria. But really, 6 of them had clear-cut evidence of exposure to tick-borne infections. Depending on how one interpreted the serological testing for tick-borne infections, 9 of them tested positive. But listen to this, 9 of those 10 had positive Cunningham panels. For those who don't know, this is testing for antineuronal antibodies. This is the diagnostic test for the PAN syndrome, for the kids who develop all of these these psychiatric and behavioral issues associated with microbial infections. 9 out of 10. So yeah, psychiatric problems are huge with these infections.
All right, very good. We are running out of time. I will try to sneak in 1 or 2 more questions here. Someone wants to know, is there a treatment protocol for people with the MTHFR mutation?
Well, actually, treatment for the MTHFR mutation is simple. We have a blockage in an enzyme, and we just bypass it by giving people 5-methyl tetrahydrofolate, 5-MTHF, which isn't a whole lot of supplements. You can get it by yourself, or you can get it in a complex, such as Thorne makes Methylguard. There's other combinations of nutrients that assist methylation, but you have to be careful, because if you accelerate methylation too fast, it's like suddenly emptying this garbage can into your bloodstream. And then people become toxic, because that it can end up dumping toxins into your bloodstream faster than your body can excrete them. So typically when people have the MTHFR mutations, we add these nutrients slowly. Again, I'm not just saying this to promote the book, but there's everything we've talked about. There's a lot more details in the book in terms of how to analyze it and how to treat it. And that this book, even though I wrote it with doctors in mind, because it's really evidence-based, tons of citations, and it gives the doctors clear-cut, here's how to diagnose, here's how to treat. It's all written in lay language, and is meant to educate and empower patients to say, oh, look, I know this is what's wrong with me. Here's how I can figure it out, or I'm going to take it to my doctor, or I can actually do this myself. So I really encourage people, because I think education is core to dealing with this problem.
Okay, how about one last question? If a person has been treated for Lyme co-infections with fairly good success, but then later on develops symptoms such as hormone disruption, GI dysfunction, what type of a doctor should they go to see to get an assessment of those kind of problems and treatment?
Well, as you know, every patient's different, and so it's hard to make a general recommendation. But the first thing I would do is go back to the Lyme doctor. And because maybe those infections have become active again and are causing this disruption that we do see all the time in people with active infections. But they could be disruptions that have occurred and continue to be out of balance. Unfortunately, this is really sad to say. I can't say that my patients have had much success going to the standard endocrinologist and gastroenterologist, neurologist. I would say go to an integrative health physician, maybe a naturopath, someone who is definitely conversant in tick-borne infections, but is really going to look at the whole patient and on a functional basis. I think that's really necessary.
Okay, well, Dr. Kinderlehrer, it's been wonderful having you here tonight. Appreciate you so much. This presentation it'll stay up on our Facebook page for a while, indefinitely, I'll say, and then it'll be on our website, palyme.org, for anybody that missed it. And everybody out there, just keep an eye out for next month. Eric Huck mentioned our next Virtual Lyme Impact Series will be third Tuesday of next month, and will be not so much a speaker, but a patient panel next month. So look out for that. So thank you very much, Doctor. Appreciate it.
You are very welcome. Thanks for this opportunity. I really appreciate you guys.
Okay. Good night, everyone. Take care.
Good night.